Hey everyone, I hope everyone had a good clinical day today on Friday, October 16th. I hope everyone was able to try something new. I was, which was super interesting. I was able to do a lot more than I have in previous clinicals, so that was super fun. So I'm going to get started on my patient that I chose today. I'm going to be talking about a 72-year-old male who was admitted 2 days ago on the 14th of October. This patient lives in Oakhurst. He went for a routine colonoscopy check, and after his appointment, he felt short of breath, and he stated that he did not feel good, so he decided to come into the ER. This patient has a past medical history of COPD, which is chronic obstructive pulmonary disease, which causes the patient blocked airways and difficulty breathing. Some symptoms are shortness of breath, wheezing, chronic cough, either dry or productive. The patients also feel very fatigued and hard to complete activities of their daily life. When this patient came in, he was at a 92% oxygen saturation, and one of the treatments for COPD is oxygen therapy as well as bronchodilators and steroids, and I know he was using a nebulizer as well, but he was on 4 liters of oxygen, and as of currently, his O2 sat was 96%. So that's why they admitted him. They also ran some chest x-rays, which I will talk about in a little bit. I'm going to start on my physical assessment. So my patient is 182 centimeters, 82.2 kilograms, no known allergies. My patient was thin build. He did not show any signs of distress. His facial features were symmetrical. His posture was symmetrical. The patient had a pacemaker in his left chest. His heart rate was regular rhythm. His CAT refill was less than 3 seconds. The patient showed no signs of edema or anything like that. The skin turgor was normal. It was less than 3 seconds. The patient had an IV saline lock on his left wrist. The site showed no redness, swelling, or the patient did not complain of pain at the site. The patient was alert and oriented ×4. The last vitals that we got, temperature 36.7 degrees Celsius oral, heart rate was 73, respirations were 18, blood pressure 134/85, and his pulse ox, like I said, was 96. His skin was dry and warm. His skin color was appropriate for his ethnicity. The patient had no tattoos. He had no bruising. The patient did have an abrasion on his left leg, on his left lower leg. And the patient also did complain that his feet were dry. Bilaterally, both of his feet were dry. Okay. The patient's nails bed were pink. The patient's hair was thin and white. The patient's mucous membranes were moist and intact and pink. His teeth were present, no dentures or anything like that. The patient's mobility was in the patient's normal limits. The patient's fall risk was a 20. He could ambulate by himself. He could get to the bathroom by himself. He has some difficulty getting up, and sometimes it takes him a couple times to lift himself up off of a chair or the bed or whatnot. And sometimes he also watches the ground while he walks. The patient's abdomen was normal appearance. It was soft, and he did not complain of tenderness. There was active bowel sounds in all 4 quadrants. He said his last bowel movement was yesterday, the 15th of October, and this patient is on a cardiac diet, which just means that he is eating a diet that has nutrient-dense foods such as fruits and vegetables, whole grains, lean poultry, fish, and it also means that it's best to avoid saturated fats, trans fats, and excess sodium and sugar as well. So, like I said, he can void independently. He does not have a Foley catheter. His last urine was yellow, clear, and odorless. The patient made eye contact. His affect was very pleasant. His speech was understandable. He was clean. And his interaction was developmentally appropriate. He was also into asking about like what medications he was taking and why he was getting them. So he seemed very into like his treatment regimen, which is always a good thing to hear from a patient. So our patient's respiratory system. So they ordered a chest x-ray as well as a sputum sample. The patient was coughing up. He did have a productive cough. He was coughing up a clear sputum. It wasn't like green tinged or yellow tinged. It was just more clear. Patient says he's breathing without difficulty. His chest was rising equally and symmetrically. He has increased aeration in his anterior lobes, so he's getting more air in his lungs, in the lower part of his lungs. So from his chest x-ray and then from his sputum samples and then also his lab results, they took a CBC, a basic metabolic panel, and they also checked his blood gases. His white blood cell came out 15.6, which is above the normal range of 4.5 to 11,000. His sodium was in normal limits as well as his potassium. His potassium was 4.1 and his sodium was 134. Everything else, his BUN was 21, his creatinine was 1.16, his CO2 was actually in the normal range, it was 25, his hemoglobin was low, it was 13.5, and his hematocrit was low, it was 40.5, sorry. So from that, and from his chest x-ray, they were suspecting an infection, and his chest x-ray showed white shadows. So he ended up getting diagnosed with community-acquired pneumonia. You can either, I think there's community-acquired and hospital-acquired, and he doesn't have hospital-acquired because he doesn't stay in like a facility or anything like that, or he wasn't previously admitted. So our patient has pneumonia. And with pneumonia, they can experience cough with phlegm, so productive cough. You can have a fever, chills, and difficulty breathing. Since he was admitted, he hasn't really been feeling any more difficulty of breathing. Like I said, his O2 sat was up to 96%, so it's in with the normal limits, and he isn't complaining of difficulty of breathing at this time. So those were the labs that were taken. For medications that our patient is getting, like I said, I flushed his IV with the sodium chloride flush. That's just, like I said, IV push, 10 milliliters. He didn't have an infusion running, so it's we do the flushes every 12 hours. He's getting azithromycin, 500 milligrams tablet daily, 3 times a day. And that's just an antibiotic for his pneumonia. And he is also getting prednisone, which is used to treat conditions such as immune system disorders, breathing problems, blood disorders, allergies, eye problems, arthritis. This is for his COPD, and it just helps reduce symptoms such as swelling and allergic type reactions, so help it with the inflammation in his chest, in his lungs. So he's getting that 50 milligram tabs with breakfast for 5 days. So we only gave those medications today. as far as nursing diagnoses, I have risk for infection, and I have gas exchange impairment. So the risk for infection, he already has pneumonia and he has COPD, which means that he's susceptible to getting more infections, or it could even lead to the pneumonia could lead to sepsis. So we want to educate our patient to avoid sick people as much as he can, practice good hygiene, stay active, stay on the diet that he's supposed to be staying on, the nutrient-dense diet. We also, for gas exchange impairment, we're going to want to educate the patient to monitor pulse ox. We're going to want to administer O2 PRN as needed for whatever the patient's O2 sat is if it's below normal limits. We also want to put the patient in a high Fowler or semi-Fowler's position at least to encourage deeper breathing and to allow the patient to breathe better. I also have on here fall risk. With the patient's O2 sat being low, if it ever does get that low again, comes dizziness and orthostatic hypotension, so he could be at a fall risk. So it's important that we make sure that the side rails are up and that he has the non-skid socks on, and that we educate him on the call light and the importance of using it when he needs it. Activity intolerance too, we just want to make sure that the patient is ambulating as much as he can. The patient was also prescribed or ordered the anti-embolism stockings, but he refuses to wear them. So the nurse on the night shift didn't make that big of a deal because he was ambulating to go to the bathroom. So I guess another nursing diagnosis could be DVT risk. So I guess we could just educate him on the importance of using the anti-embolism stockings, and if not that, then the importance of ambulating, again, keeping an active lifestyle to decrease the risk of any DVTs, pulmonary embolisms, anything like that occurring. So, let me see. I think that's it. Yeah. Yep, I think that's it. Okay. Thanks, guys.